Welcome to the 2023 Diversity, Equity, Inclusion Symposium for Bone Marrow Failure Care. I stand here with excitement on the medical advances resulting in improved knowledge on the diagnosis, pathophysiology, and treatment of bone marrow failure diseases that has resulted in improved outcomes for our patients. Through research efforts, we are starting to see real advancements resulting in tangible progress for bone marrow failure diseases, including more effective treatment options. However, we still have a long way to go. There still remains large gaps in our knowledge. We know that not all patients have the same access to life-saving treatments, such as hematopoietic stem cell transplants. We know that our patients still face many barriers to care, including inequalities in transplant referral, access to clinical trials, and the financial toxicity resulting from being diagnosed with a serious medical condition. Today, we will discuss the most recent updates and advances in the diagnosis and management of aplastic anemia, myelodysplastic syndrome, paroxysmal nocturnal hemoglobinuria, and hematopoietic stem cell transplant. By the end of the symposium, I hope we can share strategies on how to diversify clinical trial enrollment, address barriers to care for our patients, and discuss quality of life issues with the goal of implementing shared decision-making with our patients as they progress through their treatments. I want to thank the support from Alexion and Novartis to support this symposium. So again, welcome and thank you for your attendance. I turn this over to Dr. Duong, who will present our first presentation.
Okay. As I was saying, so they now call it myelodysplastic neoplasms and instead of myelodysplastic syndromes. And I think that's very much to kind of emphasize the malignant nature of these diseases. And then it also kind of makes the terminology a little bit more consistent with myeloproliferative neoplasms, which we also will not discuss today. They kind of separated this a little bit into genetically defined abnormalities as well as, and then morphologically defined MDS. And this is also kind of a little bit more in harmony, a little bit with risk stratification and treatment as well. So for example, isolated del5Q oftentimes responds to lenalidomide. Those with SF3B1 mutations, we know now respond well to luspatercept. And then there's, of course, this the dreaded mutation of TP53. And then in addition to that, if we look over here, we know that MDS with fibrosis tends to have a worse prognosis. And then hypoplastic MDS, we tend to use immunosuppressive therapy a little bit more often as well. Importantly here, so they kept the somewhat arbitrary cutoff for a diagnosis of acute myeloid leukemia at 20%. And instead of MDS with excess blasts, they call it now MDS with increased blasts. But these are essentially the same as they were in the WHO 2016. This is in contrast to actually another classification system that came out in 2022. Again, I don't know the entire story, but basically there were many scientists and physicians who kind of broke off and formed their own classification system here, the ICC. And I think that this one, again, this one also gives some emphasis on mutations, SF3B1 mutations, and then they also separate this category of patients with TP53 mutations. Probably most importantly here, though, is that MDS with excess blasts is really only one category now, and then this is what we typically think of: 5 to 9% blasts, and then peripheral blood 2 to 4%. But then they kind of made this separate category of MDS/AML, and this used to be MDS with excess blast 2, and this is the one where you have 10 to 19% bone marrow blasts or so. And again, previously what we thought of as MDS with excess blast 2, now they kind of have this hybrid category now. Okay. I think that the other important thing is that what we've known now for several years now is this concept of clonal hematopoiesis of indeterminate potential and clonal cytopenias of undetermined significance. So what we call CHIP and CCUS. And both classification systems now have formalized the definitions of this. So basically, CHIP means you have a myeloid malignancy-associated mutation with a variant allele frequency at least of 2%, but without any other formally diagnosed hematologic disorder or unexplained cytopenia. And basically, CCUS is CHIP, but with one idiopathic cytopenia. And as you can see here, the thresholds for this are actually fairly low. And there's just basically and these are basically the lower limits of most labs here. Okay. And then in terms of prognostic scoring, so prognostic scoring is probably one of the most important things that we do in myelodysplastic syndrome. It really risk stratifies patients, but in addition to that, really kind of determines what we think is their best, kind of changes what the therapeutic options are for each patient and changes the goals of care. And so this is the revised international prognostic scoring system, and it's hard to believe that this is now over 10 years old, originally published in 2012. But this separated patients into 5 different risk categories based on things that we normally think about in terms of karyotype, bone marrow blasts, and then the number and depth of cytopenias. But this is kind of what we've known now for some time, though, is that patients with myelodysplastic syndrome, about 90% of them have at least one mutation, some of which are correlated with very poor prognosis, such as TP53, RUNX1, and ASXL1. There's also various other epigenetic regulators, splicing factors, and others here. And the question is, well, if we know that all of these are associated with poorer outcomes independent of our risk scores, then is there a way that we can incorporate that formally into our risk scores? And this is something that was attempted many, many times over the last decade, and nothing really kind of caught until this molecular international prognostic scoring system came out. Now, I will say that this is a little bit cumbersome sometimes to use at the bedside, but it's a very refined risk score and it incorporates the molecular findings. So these are all the mutations here that they incorporated here. And they separate and they kind of normalize it to an average patient. And it separates you actually into 6 different risk scores here. And I'll show you here. So these are their survival curves here. And the risk categories go from very low to very high, with a median overall survival of about a decade down to only about a year or so. And as you can see here, this was somewhere around 3,000 patients or so. And so the survival curves separate very, very nicely. But again, this is a very, very complicated system. And unlike the old original IPSS score, revised IPSS score, this just isn't something that you can memorize. And it takes very high level mathematics to do this. And so there is a website that you can go to here, mds-riskmodel.com. And the nice thing about this is that it really lets you kind of not just put in all of these risk factors and such, but as you know, myeloid mutation panels here, they do differ from lab to lab. And in some cases, some mutations may not be assessed. And obviously there's a lot more mutations in this, but I couldn't fit on one page. But in any case, you put this in and it will give you the risk score as well as what the median overall survival is and the AML transformation rate. I think that the problem with this sometimes is that it's so refined that it's somewhat hard to interpret sometimes. Just this past week, my fellow and I had a patient in clinic and we got 2 different risk scores using the same model. And we looked at each other and we kind of said, what's the difference here? And what we realized is that I had used the last labs that the patient had at their outside physician. and she had used the labs that we had gotten that day. And interestingly, the hemoglobin was different by about 0.5 point, and the absolute neutrophil count was different by about 0.3, 0.4, something like that. It was like ANC of 1.2 versus 1.5, hemoglobin of 12.5 versus 13. And it actually gave us different risk categories. And you wouldn't think that at those relatively mild cytopenias that would happen, but it did. And so again, sometimes it's a little bit cumbersome to use at the bedside. That being said, it is very robust. And the nicest thing is, like I said, it really incorporates many, many mutations that we've known for a long time, changes a patient's prognosis. Okay. Similarly, we talked about CHIP and CCUS, clonal hematopoiesis of indeterminate potential and clonal cytopenias of undetermined significance. This was actually a pretty well-received paper here as well, looking at a risk score for these patients as well. And this is measured more kind of in decades because these patients tend to do well overall, but you can separate them into low, intermediate, and high risk categories here. And this is the cumulative incidence of a myeloid neoplasm. And as you can see, if you're in the high risk group here, this is actually not that uncommon, that the 10-year risk is somewhere around 50%. About half the patients will actually get that. And so this is important, although again, the question ends up being, well, if we know this, then, well, what do we do about it? Because most of the time, these patients, by definition, their cytopenias are not terribly severe, or they have no cytopenias if they have CHIP. And so then do you really treat these patients? Probably not, but I think that evidence is still kind of emerging. So I want to move on to treatment of lower risk disease. So luspatercept. So this drug came out a few years ago and was approved. So this is a fusion protein containing this modified activin receptor type 2B. It inhibits TGF superfamily and SMAD signaling, which leads to late-stage erythropoiesis, unlike our erythropoiesis-stimulating agents and erythropoietin that stimulate early colony formation here. So this was the Medalist trial that was presented at ASH in 2020 and published that same week, really. And this was a phase 3 study in patients with lower risk disease with ring sideroblasts after erythropoiesis stimulating agents. And the primary endpoint was red blood cell transfusion independence for at least 8 weeks. And as you can see here on the luspatercept arm, which is in blue, 38% of the patients achieved the primary endpoint as opposed to 13 weeks. And this is what first got this drug approved for the treatment of patients with lower risk MDS with anemia and MDS with ring sideroblasts. Newer data, though, this was the COMMANDS trial that came out. So this is now looking at luspatercept versus epoetin alpha in the first line setting, a phase 3 study. They were all transfusion dependent and again, had not had erythropoiesis stimulating agents. I should put out there that about 3/4 of the patients had ring sideroblasts and about 2/3 of the patients had SF3B1 mutations, both of which we know predict for response to luspatercept. And this was a pre-specified interim analysis and of the primary endpoint of red blood cell transfusion independence for at least 12 weeks and a median hemoglobin increase of 1.5 grams per deciliter. And this was 59% in the luspatercept arm and then 31% in the EPO arm. And these are some of the graphs here that you can see. Red blood cell transfusion independence here was pretty good here, about 65% or so. And hematologic improvement, as you can see here, is in excess of 70%. And so these data look pretty good, and the FDA agreed. And so this is now FDA approved for this indication. But we were actually just having a brief conversation this morning. The question ends up being, because such a large population here had kind of the usual mutations and morphology that you expect to respond to this agent. The question is, if you don't have those, will these patients respond as well? And there'll be more exploration, and I'm sure there'll be more studies on that upcoming. Imetelstat or imetelstat, I'm actually not sure how to say it, but imetelstat is an antisense oligonucleotide against telomerase. And so if you remember from biology, telomerase is what maintains your telomeres at the ends of your DNA. And so the idea behind this is by inhibiting telomerase function that you induce apoptosis of the malignant clone. And so the results of the phase 3 eMERGE trial came out at ASCO this past year. This was a phase 3 study in patients with transfusion-dependent lower risk non-del(5q) myelodysplastic syndrome after erythropoiesis stimulating agents. And this was a positive trial. The imetelstat arm had approximately 40% response rate compared to 15, which was statistically significant. It does come at the cost of some grade 3, 4 adverse events, including thrombocytopenia and neutropenia. And the company is now filing for FDA approval for this indication at this time. Okay. So probably more to come on that drug. I wanted to talk a little bit about oral azacitidine as well, CC486, because I think there are some common misconceptions. So unlike another oral hypomethylating agent that we're going to talk about in a little bit, the pharmacokinetics and pharmacodynamics of this drug are different than what we know for subcutaneous and IV azacitidine. And so this was actually studied only in lower risk patients with myelodysplastic syndrome by the original International Prognostic Scoring System, and they were all transfusion dependent with some thrombocytopenia. And as you can see here, so the red blood cell transfusion independent rate for at least 8 weeks was about 30% compared to 10% versus placebo, a value that was statistically significant with a fairly good median duration of response as well. The problem is it came at pretty significant cost in terms of worsening neutropenia and thrombocytopenia, as you can see here. And death within the first 56 days was higher in the azacitidine arm versus placebo arm. And because of this, this drug is still not actually approved for lower risk MDS. And it remains actually the only approval for it is actually as maintenance in patients with acute myeloid leukemia after induction and consolidation chemotherapy. So again, I think that just because, unfortunately, it's oral azacitidine, I think that we tend to think that it's equivalent to the subcutaneous and IV forms, but it really is not. And so, in my opinion, this is really not something that we should be used for higher risk MDS at the moment. Okay. I also get asked a lot about Oltrombopag. So as you know, this is a thrombopoietin agonist. And right now there's still a single blind randomized placebo controlled phase 2 trial conducted in Europe. And this is in lower risk myelodysplastic syndromes with platelets of less than 30,000. And as you can see here, Oltrombopag versus placebo, the platelet responses are higher. And the concern here, because of another drug in the past, Romiplastim, the concern was whether or not patients would progress to acute myeloid leukemia. That looks to be the same in both arms here. Interestingly, though, as same thing with aplastic anemia, Oltrombopag, there is something different about it. And for whatever reason, and for reasons that we don't entirely understand, you can actually see some erythroid improvement and neutrophil improvement as well in a subset of patients. But the use of this drug, at least for myelodysplastic syndrome, remains off-label. Some drug companies will give it to you. I have used it before. I personally still have at least some concern about the risk of progression, even though I haven't seen it in the literature just yet. Okay. All right, let's move on to treatment of higher risk disease. So the AZA-001 trial, azacitidine versus conventional care regimen, which was best supportive care, low dose cytarabine, or intensive chemotherapy. This came out more than 10 years ago, and it remains the only randomized clinical trial in MDS to ever show survival benefit, 24.5 months versus 15 months. And so the question always has been, though, is this something that we can improve upon, or give alternative ways here to give it? And so this is oral decitabine, otherwise known as Inqovi. So decitabine with cedazuridine. And what it is cedazuridine, what it does is it protects your decitabine from deamination in the GI tract. And so it makes it orally bioavailability. So it's available in a tablet form. This is now approved for higher risk myelodysplastic syndrome and CMML. This was a kind of an interesting study design, their phase 3. So basically what they did is, so they randomized patients to either standard IV decitabine or this oral agent, and they randomize you to which one you got first, basically, okay? And whichever one you got first, then you got the other one for cycle 2. And what they did is basically measured the pharmacokinetics after cycle 1 and measured them after cycle 2 and compared them to each other to see if they were bioequivalent. And that was the primary endpoint, and it was met. The total 5-day decitabine area in the curve equivalence was 99%. And so what they proved is that really it doesn't matter which way you give it. And actually thereafter, they gave everyone the oral Inqovi thereafter for each cycle. The complete remission rate was 22%, which is fairly consistent with what we've seen with hypomethylating agents in general. And I think that, to me, what was fairly impressive is that at the last update, the median overall survival was 31.7 months. And for this population of patients, that is quite impressive, even higher than what we saw in the AZA-001 trial, which people were wondering because that had never really been replicated. And so to see this median overall survival is comforting, although I don't know that obviously that will translate into the real world. Azacitidine combinations. Unfortunately, this is kind of the boulevard of broken dreams here, especially over the last few years. So Apria Therapeutics had this drug called eprinetapopt, and specifically in TP53 mutated myelodysplastic syndromes, it was supposed to kind of restore the wild type conformation. The early phase 1 and phase 2 data looked really impressive in terms of response rates. But unfortunately, in 2020 here, in the end of 2020, there was a press release that showed that this trial failed to meet its primary endpoint of complete remission rate, even though numerically it was higher in the eprinetapopt with azacitidine compared to azacitidine alone. And then the next disappointment came with pevonedistat, a NET8 inhibitor. And so this was once again azacitidine versus azacitidine with pevonedistat. And in 2021, Takeda put out this press release saying that this also did not achieve its primary endpoint of event-free survival. And then most recently over the summer, magrolimab, an anti-CD47 antibody that looked very promising in early phase studies, especially again in patients with TP53 mutations, once again, unfortunately failed to meet the primary endpoint. And this was actually just based on the interim analysis, and it was stopped due to futility. And so unfortunately, 3 combinations that unfortunately have failed. What everyone always asks about is azacitidine with venetoclax. And so that you know, if you're familiar with the dosing in acute myeloid leukemia, we do give less venetoclax in patients with myelodysplastic syndrome. You only give it between days 1 and 14. And these are the latest data that will be presented at ASH this coming year in a couple of weeks. But as you can see here, the modified overall response rate here was 80%, which is pretty impressive. And certainly more than we've seen in the past. The CR rate may be a little bit higher than we've seen in the past at approximately 30%. As it stands right now, the phase 3 study is ongoing. For those in the community who may use this, I do want to emphasize, though, that the cytopenias do tend to be much deeper than with azacitidine alone. So it's something that we do have to be conscious of and be careful about. So other azacitidine combinations that are or will be soon in phase 3. So MBG453 is sabatolimab. It's a TIM3 inhibitor. And this is being looked at in combination with azacitidine with intermediate high or very high risk myelodysplastic syndromes. And then in addition, this other drug, tamibarotene, which is a retinoic acid receptor alpha agonist, is also currently in a phase 3 study compared to azacitidine alone. Well, azacitidine plus tamibarotene versus azacitidine alone. So these are upcoming. I don't think that we'll have results at, certainly not at this ASH, and it'll probably be a couple of years before we get results from those trials. Okay. And then lastly, kind of the holy grail here, the outcome, the hypomethylating agent failure. So unfortunately, it's been shown time and time again that patients after hypomethylating agents, especially if you have higher risk disease, these patients fare very poorly. And as you can see, the overall survival here is consistently less than 6 months. So this is always the area of need because we know that all patients, no one gets cured with hypomethylating agents. And so we always need to know what's next if those patients fail. And as you can see here, so options after hypomethylating agent failure, there truly is no standard of care. And this is an old study, but this first line here, the patients that did best and with a tail end here, of course, this is patients who went to stem cell transplant. Interestingly, though, the next line of therapy, patients who did next best were the patients who got investigational therapy. Now, of course, there is some significant bias here in that obviously patients who get to transplant or who are able to go on investigational therapy tend to be more healthier, more fit, et cetera, so that they can actually receive these therapies. So there's some bias here, but it does kind of go to show you that, you know, this is really an area of unmet need and we really should be enrolling these patients in clinical trials. So the next question again, so then the question is, well, how about I just add venetoclax? And there may be some merit to this. So this is a phase 1b open label study at various doses of venetoclax for 14 days. And even though the complete remissions are relatively low here at 7% or so, this is marrow complete remission. So what that means is basically you clear out the bone marrow of blasts. However, your blood counts don't improve to requisite levels. But sometimes that's at least enough to get patients to transplant. And as you can see here, it's about 32%. And so an overall response rate of about 39%. Not too bad considering you're just adding one other drug on that's an oral drug. Again, remains to be seen whether or not this is something that's going to catch later on. And who knows if azacitidine with venetoclax ends up being first-line therapy, then what do you do after those patients? We don't know. There is some good news in this that I want to talk about here. So IDH inhibitors, granted, this is a small subset of patients with myelodysplastic syndrome, somewhere around 5 to 10% or so. But with enasidenib and IDH2 inhibitor, this was a study from MD Anderson, and there were 23 patients here, and the ones who responded fairly quickly in 27 days, with an overall response rate of 35%. And then median overall survival was 20 months, which is not bad, again, considering traditionally it's less than 6 months. So there's probably more to come about this one. And then actually just at the end of October, ivosidenib is what became FDA approved for patients with myelodysplastic syndromes with an after hypomethylating agent failure with an IDH1 mutation. It is based on a study of only 18 patients, of which 15 had a prior hypomethylating agent, but the complete remission rate was 38.9% in a median time of only 2 months. And so again, this is now FDA approved, and at least for a subset of patients, is something that we can offer them. Okay. And that's all I got. And I'd be happy to take any questions. Sorry, that was a bit of a whirlwind, I know. Yeah, I mean, that's a great question. I think, for the most part, I am kind of using the risk model, and it's tough because the vast majority, well, I won't say the vast majority, many of these patients won't develop anything later, and you kind of wonder, but it causes a lot of anxiety, I think, a lot of times. And so really what I try to counsel them about really is just saying, this is something that we know about, and this is something that we're going to follow. I do talk to them a little bit about the known cardiovascular risk in patients with CHIP and CCUS, and I talk to them about mitigating their other risk factors and such for that as well. But really, I'm just telling them that, yes, unfortunately, you are going to be at increased risk of a myeloid malignancy in your lifetime, but we don't know if it's going to happen or not. And at least right now, most of those patients, I'm watchfully waiting. The higher risk patients, you do start to wonder if there's something that you should do about it, though. But as of now, there's no evidence to say that you should. Any other questions? Okay. All right. Well, thanks again, everyone.